My name is Dr. Veronica Neumann. I'm one of the doctors here at Seattle Nature Cure Clinic. Some of the docs here, including myself, are supervisors for the Sports Med Club. So that's kind of the connection. And then when I was a student at Bastyr too, I was also in the Sports Med Club and then present for my last year. And so love the club. Glad you guys are back in action. That's great. I am a naturopathic doctor and acupuncturist. And so I guess this talk with trigger point therapy, it is a little controversial just because needling, it's always a topic of should naturopathic doctors needle or should we leave it up to the acupuncturists? But I think it's such a helpful tool and helpful therapy that I think if people have the training for it, that it should be done. I see it in practice. I do it on most patients, to be honest, with musculoskeletal pain. And it works great. And so if you're able to do it, I think anyone who can should. With that being said, too, I think you don't always need a needle to complete this therapy. Once you're able to find a trigger point, there's other ways that you can release the trigger point, whether that be a needle, your hands, whatever. So I'll touch a little bit of both, but in practice, I generally use a needle, but that's also just because I'm an acupuncturist as well. Oh, great. So you'll see the presentation opening up. That is wonderful. So right now I'm starting on slide 2 for what's the difference, because you hear a lot of different types of terminology when it comes to trigger point. And so for acupuncturists, they use the term ashur, is how you say it. Some people say ashi. And so that's the traditional Chinese medicine term. And that's rooted in the philosophy of qi. But in general, it's just a painful point on, it doesn't have to be on a channel, but it's a painful point on the body. Then there's trigger point therapy or needling. That's what we'll be talking about today. And so a lot of times it's called myofascial trigger point, MTP. And so it's a tender point on muscle or fascia. A lot of times when you press it, it creates referred pain to other spots on the body. And so you'll find that there's these referral patterns. And once you can recognize them, it kind of helps you figure out where the trigger point is. And a lot of times too, these trigger points will have a local twitch response. So you know that you're on it because you press it and it'll just twitch. So that's kind of your indicator that you have found it. Some people use the term dry needling. And this is more so used by people like physical therapists, chiropractors, or maybe athletic trainers. It's usually a certification course that they do. And this ranges from like 100 hours completed or 200 maybe. So it's just a certification course. It differs from wet needling because you're not injecting anything, but dry needling is just you're sticking a needle where there's tenderness. And then you'll also hear terms like intramuscular stimulation, motor point stimulation, neuromuscular needling. And all of these are pretty much the same thing. It just depends on your background and education, which term that you're able to use. So on the next slide, you'll see kind of the scope. I just did Washington. Depending on where you practice, you'll want to look up what you're able to do and what term you're able to use. But if you're an ND in Washington, you can do this. I just want to reiterate, you'll want to make sure that you have the appropriate training. So after this talk, I don't think you'll be able to complete it. You'll want someone mentoring you and guiding you through the process, but use the term trigger point needling if you're a naturopathic doctor and not an acupuncturist. If you're also an acupuncturist, you can say ashur needling or trigger point needling, whatever one you want. But NDs, I guess the scope in Washington is a little vague. It falls under the manual manipulation scope. And so this would be the mechanical means that you're doing the manual manipulation. And it is, I mean, you will have the education for it just because you're able to do the intramuscular and other types of injections too. So I think you'll be able to do it with the proper training. And then other providers, which we already touched on, like PTs and everything, they're actually not able to dry needle in Washington state. There's 7 states where it's not allowed, and Washington is one of them. Other West Coast states also, that's pretty common. Other states, it's certification programs that they're able to do it. So wherever you practice, just know the laws and know what you're able to do. as like anything. So moving on, so what is a trigger point? We kind of talked about some of the different terms and definitions, but basically what it is, when you palpate, there's an area of tenderness, there's a referral to a distant site. These sites, I guess the common ones, you'll see a lot of, and you might have already seen it already in clinic, neck pain that refers to the head. Very common, but there's also spots in the glutes going down to the feet, but a lot of eyes, neck area type of thing. And some of the things that can cause a trigger point to happen are it's past injuries, mechanical stress, posture can do it. You can imagine that student position, repetitive strain if you're sedentary, even sleep, and even nutritional deficiencies might be able to cause this problem. And so that's what a trigger point is. And it is like if you picture a bundle of fascia, muscle, nerves, that's what it is. And if you look at the physiology, there's a few different ideas of why this happens. But the basic knowledge of it, as far as we know, is that there's trauma from whatever factors we just said, and that damages the sarcoplasmic reticulum in a muscle. And once that damage is done, that allows calcium to leak out, that interacts with ATP, and then the myofilaments are activated by the ATP, so that's the actin and myosin kind of moving back and forth. So that shortens the sarcomere, so you can imagine it feels like that. So the muscle shortens, and then there's that muscle hypertonicity. And so that's what you're feeling, and you can do this on yourself too. Like you can probably find a few trigger points as we're speaking. The muscle feels tight, so that's what you're looking for. And there's a few different types of trigger points. In the next slide, you'll see it's labeled MTP. That stands for myofascial trigger point. So if you see that from here on out, that's what it means. And so there's active trigger points. And so this is a spot where you're feeling and it feels tight, it sends that referral, it's textbook, that's active. You'll see it twitch when you press on it or whatever modality you're treating it with. A lot of times the patient winces and they will give you feedback when you have touched the trigger point. And a lot of times if trigger points stay untreated and they're just sitting there, they can recruit neighboring sites. It's called satellite trigger points. And so you might have multiple areas of trigger points, but there's one mega trigger point. So a lot of times if you treat that mega one, that initial one, the satellite locations might just go away from there. And then there's also latent trigger points. And so this could also happen when the trigger point isn't treated. It might just go into that latent phase. And this could cause more muscle weakness, and it stays in that shortened phase, I guess. And so trigger points can move back and forth between active and latent. But the latent ones can be reactivated if there's trauma, something acute happened, cold or stress. And some of you acupuncturists, this might fit in with the acupuncture philosophy. They would call it a wind-cold invasion. And you might know this from your everyday life. If you sleep with the window open or if you have your fan running at night, sometimes you wake up and you just have a really sore neck. That's the idea of wind-cold invasion. And so that can activate a trigger point. And that's an acupuncture philosophy. So how to locate. You definitely want to hear a patient's history, like what is going on. And so if they're like, my neck hurts, you're going to look for a trigger point in the neck, most likely. That's where you're going to start. But there's all the PE that goes into it too. So that's range of motion, looking at someone to see if their shoulder is elevated or not, if you're looking for upper extremity type thing. So orthopedic tests is another thing. So look at those. And then once you find what area of the body you're going for, what you're going to look for, you palpate the muscle and you go cross fiber. So if your muscle the fibers are going across like this, you're going to palpate up and down. And that's where you're looking for the nodules. I guess in layman terms, it's like you're looking for a knot, a muscular knot. Once you think you find it, you press on it and you see if there's a twitch. And so it's just a muscle spasm that you'll feel. And then you also get feedback from the patient and ask, like, did that refer anywhere? Let's say they come in with eye pain and you're looking for a trigger point. You would ask, does this point aggravate the eye pain? So it is a communication with the patient as well. And once you think you have found the trigger point, it's so much easier if you just mark it. And so at office here at Seattle Nature Cure Clinic, we have surgical pens all over the office. It's so when you find an area that needs to be treated, you just put a big X on it. So that way you don't have to keep activating it when you don't want to, and you're just trying to find it. You have it marked, and now you can just treat the whole rest of the office time, and you'll know exactly where it is. So that's how to locate the trigger point. The next slide just kind of shows same thing of how to identify it. Same thing, top palpable band, spot tenderness. The patient will tell you it hurts. And then there's other sources that say you'll find a trigger point when there's painful range of motion when you press on it. So that's just another way to find it. Some modalities. Needling, that's what I use. But unless you have the training for it, the other things that you could do would be manual release. And so that could be, I think, one of the best ways to release things. It's active release technique. And so what that would look like would be, we'll just use it since it's visible on the screen, but if I have a trigger point right here, I would press on it and then have the patient look opposite direction and then back forward again, very slowly. And you just keep doing that while you're pressing on the trigger point. It hurts, but it feels so good after. It does a great job of releasing it if you don't have the needle. I'll say the needle tends to work a little better because it's almost like a massage from the inside of the muscle because the needle is able to go deeper. With just palpation and manual release, you're having to go from the outside and press in, but it can still be effective. So a valid way to release the trigger point. Ischemic compression is just pressing down on it. That works, or massage. Massaging in circles doesn't really tend to do it. I would say that ischemic compression and really just pressing down on it and holding is what does it, but incorporating the active range of motion does wonders. I would do that for sure. You can also use therapeutic ultrasound on it, whatever tools that you have. Laser, like at clinic, if you have the laser. Be careful with laser if it's high power over like lung field or certain things where there shouldn't be growth, just because laser can stimulate growth factors. So like over the lung field, you don't want the lungs to grow any lesions. That wouldn't be great. And then the next step too would be trigger point injections. And so once you find a trigger point, you can inject it with lidocaine or other substances as well. I don't usually jump here. I usually like to try everything first. Remember your therapeutic order. That is a higher risk intervention. So if someone's not getting better, it's usually try the first treatment, have them come back. If they're like, yeah, it got better, but then it slowly started returning again, I usually would repeat the treatment again. Sometimes it just takes a couple times. And if they come back again and they're like, oh, same thing happened, it came back, that's when I would step it up. Then I would go to the injection, or I would pair the needling with manual release and laser, something like that. But just remember your therapeutic order and lower force first. This next slide is for if you're using needles, the selection of it. And this kind of goes with any modality you use. Always figure out if your patient is vital or not. What is their vital force? Sometimes the active release technique, even on some people, is a little too strong. So just doing the ischemic compression is a good place to start. And if you're using needles, I wouldn't ever use anything bigger than a sarin red on shallow muscles. If the person is chi deficient or low in a vital force, I would use green needles, which are smaller. And I guess the summary of this slide is if it's a big muscle, you're going to use a bigger or longer needle. If it's a small muscle, you're using a smaller needle. And with that being said, like things on the erector spinae group or rhomboids, it's helpful if you know how to use an ultrasound to do ultrasound guided needling, because erector spinae group or rhomboids, they're over the lung field, and one of the risks of using needles is a pneumothorax. And so ultrasound, it enables you to see the lung field so that you don't go too deep, but you can go deep enough in the muscle where you're able to get the trigger point release. And so that's something that's usually learned in, I'm sure there's classes on it, but mentors, if they know how to use an ultrasound, that's also a great resource of how to use an ultrasound. Also, YouTube videos are free for ultrasound guided needling and injections. Are actually a great place to start if you're just wondering about how it's done. Okay, so now how to perform. This is more so for needles, but you could apply some of the same techniques for other modalities. So we talked about how to find the trigger point, how to locate it. If you're using needles, you use a clean needle technique. So make sure that area is clean, your hands are washed, that sort of thing. Once you find the point, again, I'll use my upper trap as a demo, you want to create tension in the muscle. And so if I'm needling on the upper trap, I pinch the muscle. You're trying to really create tension. And so you pinch, it also lifts it so it's away from the lung field if you're going for the upper trap. And then you insert the needle. And then it's not just inserting the needle and leaving it there, it's a lot of needle movement. And so there's thrusting where you're going in and out, and then twisting the needle to rotation. And so it's a combo, you're doing both at once. You're thrusting the needle and rotating it at the same time. And that's usually when the twitch happens. A lot of times you insert the needle to depth and nothing happens. The twitch happens when you're rotating and manipulating the needle. And since we talked about tension, a lot of times you need multiple needles for the same muscle, not always. But if it's the upper trap, a lot of times I'm putting anywhere from 1 to 5 needles in it, because each needle, as you're twisting it, picture the fascia kind of bundling up around the needle. It's creating more and more tension until finally it just releases. And so I like to check back on my needles. Like, let's say I do have 4 needles inserted on the upper traps. Once it starts to twitch, I'll go back to the other needles and twist them again. And needles that weren't twitching before might twitch after you've created enough tension. So it's always good to go back and see if the needles will create a trigger point response and a local twitch response. And then after that, after you've hopefully got some twitches, then you can either leave the needles in if you're working on another body part, or you can just remove them. So up to you. I usually will leave them in if there's another part of the body that I'm treating. And so now it would be good to practice on yourself. So because it's really easy to find trigger points. And so the easiest spots to find them on yourself will be your upper trap, your SCM, or your calves. But right now, go ahead and try it out. And so
Dr. Veronica, it looks like you're frozen on my end, at least.
Yes, I'll text her.
Thanks, Rika.
okay, am I back?
Yes, hello.
Thank you.
Okay, great. Yeah, it looks like we lost internet connection in office, but I am using my phone as the hotspot, so that should work now. Okay, so I hope everyone had a little moment there to practice, but find your trigger point. You'll know if the pain is referring, that you found it. Maybe you're wincing. That means it's like, yep, that is it. And while we continue on with the talk, feel free to just palpate whatever you feel you need. And if you have questions on like, oh, is this a trigger point or what is this? Just let me know or let Nicole know. Okay. So the contraindications of trigger point therapy would be if you are needling the neck or torso area and you're a beginner. Just remember there's a lung field, there's so many important blood vessels and nerves in the neck as well. So you're going to want to be careful around this area. Also, be careful if there is an infection. So I feel like this is common sense, but I'm just going to say it anyway. If someone has a big gaping wound that's infected, don't needle there. That's not good. But also if there is systemic infection and you don't want to worry about a puncture causing more infection, just don't do it. You could do the active release technique or other ways to release the muscle. And then if someone has a severe bleeding or anticoagulation disorder, think twice about needling. But once again, you have other tricks that you can release a trigger point with. And so side effects. This is super important to talk about with your patient because the soreness is real. If you've had trigger point therapy done before, you are sore for that day, maybe the next day, hopefully not longer than 2 days. But you're going to want to tell the patient they're sore. And I always say, like, hey, if you have anything really big coming up in the next few days, maybe we don't do this right now, especially if they're an athlete and they have a big game the next day or a big match, whatever it is. Just give them the heads up. You're going to be sore. Is that okay? Bruising, that could be another side effect. Not always common, but it could happen. Infection with any type of puncture or injection or needling, it's possible, usually not likely. Nerve injury could happen, pneumothorax could happen, but all of this, it won't happen if you just know your anatomy, you're using a clean needle technique, you're using the ultrasound on the torso, that sort of thing. And so there are ways to prevent side effects. You should do them, but otherwise the biggest one is soreness. And you might have other modalities where, to get rid of soreness, so you can tell people, drink water, take an Epsom salt bath, do contrast hydrotherapy if it's really bad. But most of the time it feels like a good soreness where it's like, oh, maybe I just worked out, that type of soreness. Okay, so the next slide is a demonstration or a picture rather of a referral pain pattern, a really common one. So it's showing the upper trap and then the sternocleidomastoid referral pain pattern. And so the X on there, like to the picture on the left, that's where the trigger point is, where you'll find often that referral pain pattern, it's tight, it doesn't feel good. That's where you would needle or press. And the referral pattern is up into the neck and around the temporal region and above the eye. And then the picture to the right is the SCM. You can see there's so many trigger points on this muscle all up in there. And that'll be like head, eye, face. So if someone's having just weird eye pain, you might want to look at that muscle. The next one is all of the shoulder, rotator cuff muscles. Lots of scapular trigger points that you'll find in both the supraspinatus area. This article called it a subscapular trigger point, but that looks more like infraspinatus to me. Pec minor's trigger point is in the axilla. And biceps, it's showing kind of at its attachment, almost overlying the pec muscle. But I find that the biceps, if you can find a trigger point right on the tendons on the shoulder. Like I see where Nicole's pressing right now, exactly there. You'll find a lot of trigger points in the biceps right there. And then the next one is glute pain referral. For that one, you'll find a lot of trigger points kind of along the TFL and then the upper part of the glute med that'll send the referral pattern all the way down to the foot. And I would say the most common places that I trigger point, like number 1 is the neck, number 2 is the glute, and then there's a lot of other ones that could be tied for third, but I would say those are the 2 most common places that I needle. And then I included a few cases to think about, like how to apply this in the real world. And so let's just kind of go over these. And I'm not sure if Google Meet has a, what do you call it, a talking function, or if you guys just want to voice it out. But like if someone comes in with low back pain, you can think about their history. This one's a little more straight up, like you could ask things like, when did this happen? Where does it hurt? PE, and feel free to shout it out, but I know a lot of people are probably eating lunch and you can focus on that too. But PE, you could do range of motion, your orthopedic tests. Where do you guys think you could find trigger points for the low back? What muscles?
I often find them in the glute med and like glute max kind of upper attachments.
Yes, that's like one of the first spots I would go. Any other ideas?
Did you say the low back? So like the QL?
Yep, QL would be a good one. QL, I always do ultrasound guided just because there's a risk with the lower lung field. So I usually use the ultrasound for QL, but you could definitely go there. Any other spots? Another area you could do is the erector spinae group, just right in the low back. Those are really tight on some people, and you could trigger there. And another spot that might not be as intuitive would be the psoas muscle. Lower cross syndrome, you could think that might be really tight, causing the back pain. And you can get that to twitch pretty easily too. That's another one that I use the ultrasound for, because think about all of the arteries, nerves, and veins, like the femoral artery and nerve that are coming near the psoas. So I just make sure that I'm not hitting any of those. And so that's what you could do for low back pain. But I think the glute would be the first place that I would go. And that's also with history and what you feel on palpation. Everything is based off palpation in the end of where you go. Another one that you can think about, so let's say it's a 32-year-old female with headaches. Get your history, figure out if it's referring anywhere. PE, you could do everything head-related, ruling out things with the eyes, whatever the history is telling you. What trigger points do you think are correlated with headaches? What muscle groups? Any ideas?
The SCM is a big one.
Mm-hmm. Yep. I would do SCM, upper traps, anything paracervical. With headaches, I do a lot of scalp acupuncture. So the attachment of upper traps or levator scapula, also like in the very back of the head, you can feel really tight bands. And this is where I use the really small needles. So for you acupuncturists here, the dark green sarin needles. That's what I use for the back of the scalp. I'm cautious around the occipital nerve of the head, but that's why I use the small needles. But that can be really helpful for headaches. So I'd say upper traps, levator scap, scalenes, SCM is where I would go with the headaches. And then the last kind of application of it, and this is what I do, I would say, I don't want to give a percentage, like 30% of my patients I feel like have plantar fasciitis. And the number one tool for it, I think, is trigger point therapy. It works so well. So if someone has plantar fasciitis, what muscle groups do you think you would trigger point? Would you put it in the feet? No, that would hurt a lot. Yes, I heard someone say, I think Alyssa said gastrocs. Yes, gastrocs, definitely there. Any other places? I would also look, I'm not sure if I'm just like not hearing people either, but hamstrings. So like keep working up. Like I would start the gastrocs and then build up. Check the hamstrings, check the glutes, everything connecting up. Heck, you might even find with that fascia line that have low back trigger points. But number one spot I go to first are the gastrocs. And you will find so many trigger points in anyone's gastrocs. And once you release that, it feels so good on the plantar fascia. I don't do trigger points on the plantar fascia because it's not really a muscle that would twitch. There are acupuncture points in the feet that I sometimes thread the needle like on the bottom of the feet so they're almost like touching each other if they have really bad plantar fasciitis. And then I do electrostim on it too. There's a lot of manual work you can do too on like the inside of the arch as well if you're not using needles. But getting the gastrocs to trigger, it's key for plantar fasciitis. It's like you can do in-office treatments with like laser and shockwave, whatever you have, ultrasound. It's so good for the bottom of the feet where the pain is. But the thing that's going to make it stay away is working on the calves and the hamstrings. That'll keep the plantar fasciitis away. It's a real game changer. And then, of course, having people stretch at home too, that can help as well. But that's kind of my whole spiel on trigger point therapy and trigger point needling. I would say the best way to learn more about how to do this would be step one is probably getting on Dr. Massa's shift. Sometimes I'm here subbing for it, but right now it's Dr. Massa and then his resident Dr. Tom. You'll see a lot of trigger point needling done on shift. And then the next step would be taking any classes by integrative medicine group on either Osher needling or trigger point. And then I would say after those, you might be able to do some trigger point on people after that. But there's also certification courses that if you really want to get good at it, that's where you would go. If you're an acupuncturist, you can probably just, after that little bit of mentorship, either in a class or on shift, that should be able to get you by so that you can practice on people and feel confident about it, and that you're not going to hurt anyone. But if you're not on those things, on those shifts or taking those classes, you're definitely going to want to go through like a certification program, because a lot can go wrong with this. Like I hear about it all the time of people just going for the needling and then causing a pneumothorax. Like it's dangerous. It's not great. You want to make sure you're trained in this. It's kind of like how functional doctors out there, it's like, oh my gosh, they're giving, it's good advice that they're giving, but it's like we're like naturopaths are trained so much more in it. And so they're trying to do good. That's great. But there could be some things improved. And it's almost like that with acupuncturists and trigger point needling. Like, make sure you're trained if you do it. You're going to help people if you know how to do it. So that's great. Love the idea of people getting trained in it. That's kind of the bottom line on it. But are there any questions?
I have a question.
Yeah.
So in the past, my knowledge of trigger point needling was more like getting injections and then doing, you can't just get the needling, you have to then get manual therapy after. And this seems better because, you don't have to go make another appointment. It's less invasive, more low force, and it doesn't require you doing like massage and stuff. Do you think it's as effective for releasing the trigger points just doing the it seems very gentle and just very low force? Do you think it's as effective as that, like numbing the muscle and then doing manual therapy?
It depends on the patient. I would say I think it's as effective. For some people, it's like chronic. So let's say this has been something that's been happening for years and years and years. The lidocaine or whatever numbing agent you're using, that is kind of like a neuromuscular reset when needed. But I just don't always think it's needed. Some people have such a injection phobia where it causes more harm than good. And so I like to see how people do without it first. And I also love to pair the needling with the injection. So I do the trigger point with the needles, and then I usually do the injection right at the needle site. So I mark which needles were the most reactive, which ones twitch the most, because I'm trying to find that latent center of the trigger points, like the mother lode of the trigger points, And so I circle it, and that's where I'll do the injection. And I keep the needle in there after the injection's done, and I spread the lidocaine with the acupuncture needle while it's still in there. But yeah, I don't have to go there very often. Like I would say 1 in 6 patients I end up doing the lidocaine injection for, and everyone else, it just works fine without it. Any other questions? Nothing. Okay, great. And I think, was that anyone? This could be a good time. I mentioned a little bit about the classes. I think there's an upcoming IMG class if someone wants to mention it.
Yeah, there is. I'm just opening up my document now to see how many spots we have. It's next Saturday from 9 to 5 with Dr. Massa at Seattle Nature Cure Clinic. For students, it's $300. For professionals, it's $375. There's a $100 deposit due before. There's a nice long PowerPoint for us to prepare for class with. But if you're interested in that, there are still a few spots left. Yeah, it's going to kind of just delve deeper into this. Like, this ended up being perfect timing. He actually just did a class like this 2 weeks ago, and there was so much more interest that we have a whole other list. So this was so great, Dr. Veronica. Thank you.
Yeah, thank you so much.
Yeah, thanks for having me. And it sounds like this is recorded. You guys can share the slides if you want. So yeah, and if you have any questions, feel free to email me. Nicole or Rika will have that if you want my email. But yeah, thanks again for having me. Have a good rest of your day, guys.
Thank you. Thanks, everyone.